In the case of stress fracture, we know that someone who only participated in one sport in childhood has a higher risk of stress fracture than someone who participated in several sports.
Problems with the hip joint are a common reason for a consultation with an orthopedic specialist. Today, I'm talking to an expert in this field about what needs to be considered, especially for athletes. Mr. Schoch, you are a qualified physiotherapist and lecturer and have been involved in sports medicine and joint health for many years. Why is the hip so important for the statics of the body?
Yes, the position of the hip is in the center of the body. And that's where the transfer of force takes place, either from the legs upwards to the spine or to the upper extremities or from top to bottom, for example, when throwing, via the hips to the legs. And that's why I'd say that's the pivotal point, so to speak, of power transmission or weight distribution.
What role does the hip play in sports injuries, in amateur and professional sport? And what are the most common pathologies, and how do they manifest themselves?
They say that hip injuries account for up to 10% of all sports injuries. And if you look at the individual sports, the figure is higher. We're actually talking about 10 to 23% of hip injuries in soccer or ice hockey, for example. There are often acute injuries. That is, injuries sustained while practicing a sport, but these tend to be muscle and tendon problems. A hamstring injury would be more typical, for example, in sprinting, soccer, or ice hockey. But then there is also the problem of straining due to specialization too early in sport, for example. There is good data from ice hockey that shows that even young athletes develop hip impingement, which then leads to long-term consequences.
Patients usually consult their GP first. When should they listen closely when it comes to the hip and refer them to a specialist?
I think that when such an athlete comes to the GP, the primary task of the GP is actually to clarify the red flags. That is to rule out the worst. And if, in the end, the hip pain remains as pure hip pain, then I would send them to a specialist. But it would be important to me that the GP clarifies, is there a fracture? Is there a tumor? Is it an infection? Is it something internal, or is it perhaps coming from the spine? A good differential diagnosis should be carried out to rule out anything serious, and then I would send the patient to a specialist. But you should always keep the lumbar spine in mind for all patients. There is a study that shows that over 60% of all complaints in the hip and groin area come from the back. So you should always keep that in mind.
Just how important are prevention and rehabilitation after an injury, especially with sports injuries to the hip? What do doctors have to bear in mind?
If the problem is there and the injury is present, I see the main task of rehabilitation as progressively increasing the level of exercise again and thus getting the tissue and therefore also the athlete or amateur athlete patient used to the strain again. This is not based on the time factor. That is saying you can run in 3 months. In 6 months, you can do contact sports again. But based on functional criteria, this means that you perform functional tests, for example, a front hop test, or see how the patient reacts to stress, swelling, warming of the joint. How does the joint respond 24 hours after exercise? This is always very important. And so I can then very slowly and progressively increase the strain and get the patient back into sport. This is where I see the importance of rehab, because otherwise re-injuries will occur, or there may also be fears. There are also psychological factors that play a role that we can address. You have to prevent the patient from doing nothing at all, which is also bad for their overall health. That's why I think rehab is important. In terms of prevention, this is perhaps also important for doctors in general. It's important to point out to young athletes that they shouldn't specialize too early. In other words, the earlier they specialize, the higher the risk of injury or overstraining. The more broadly children and young people are already involved in sport, in other words, the more different things they do, the better it is for the development of their bones. In the case of stress fractures, for example, we know that someone who only played one sport as a child has a higher risk of a stress fracture than someone who played several sports. But it's also important to manage your workload, to take a day off during the week, especially when you think in competitive sports. You have to limit the number of hours of this specialization a bit. With children, it is said that they should train for the amount of hours corresponding to their age per week. In the case of 9-year-olds, this means that it is better to only do 9 hours of specialized training per week. This should be monitored more closely, and parents should be made aware that specializing too early and overworking them will simply lead to more problems later on.
When it comes to age, at what age is it okay to specialize as an athlete?
Middle adolescence, from the age of 15. Some coaches will probably say that's far too late for competitive sport, but that's definitely the recommendation.
You just mentioned the psyche. What do doctors perhaps need to consider so that they can respond to the patient in the best possible way?
If you think of children and adolescents, it would be good to take the stress off them in general, meaning not to place too many expectations on them. High expectations are a problem. Then also these negative experiences, if I don't win or something like that you really deal with it well and don't create any fears. If there is an injury, patients in competitive sport are always well looked after psychologically. But the amateur athlete actually has the same problem. They want to do their sport to feel good and maybe achieve something. They are also often afraid. What will happen next? Can I return to my hobby? Or they are afraid of movement because they have experienced this pain and don't want to experience it again. You have to talk to the patient and make clear, your pain doesn't mean that something is about to break, it's just a warning sign. And if you apply pressure very slowly and it hurts a little, it is not a problem. We often use a pain scale and say a pain level from 2 to 3 is still green, 3 to 4 is orange, and a pain level of 5 and above is red. And then you'd better stop and do less of it. You can actually coach people quite well that way.
To conclude, what advice do you have for doctors when dealing with the topic of hips and hip injuries? Is there still room for improvement in your opinion?
There are actually quite good agreements. For example, there is the Doha Agreement and another agreement from 2018 from Zurich, where all the hip experts came together. It's actually relatively clear how you should proceed diagnostically. That is what tests you can do. The agreement also mentions X-rays. I would never treat or operate solely on the basis of the X-ray. You simply have to take various components into account. This agreement says, for example, that if someone has hip impingement, you should first do 3 months of training. If it's actually a hip problem and if the red flags are ruled out and it can simply just be the hip diagnostically, a conservative trial of at least 3 months is actually always indicated first, and only after that we should consider whether the patient should have surgery or not. This would apply, for example, to femoroacetabular impingement, cam impingement, or pincer impingement, where the patient undergoes surgery relatively often and often rightly so. But a conservative attempt should always be made first or at least discussed. I think the most important thing for patients is good communication.